Thyroid gland diseases in children. Riga Olena. KHNMU. Excretion of iodine in urine. 100 to 200 grams/L, normal level. 201 to 299 grams/L, increase level. Greater than 300 grams/L, increase of intake in food. Deficiency. Less than 20 grams/L, severe. 20 to 49 grams/L, moderate. 50 to 99 grams/L, mild. The steps of thyroid hormone synthesis. Monoiodotyrosine, MIT. Diiodotyrosine, DIT. 1 molecular MIT plus 2D-thyroxine T4. 1 molecular MIT plus 1D-triiodothyroxine 3. Under thyroperoxidase control. Peripheral conversion T3 from T4. Both T4 and T3 circulate in plasma bound to the plasma thyroid hormone binding protein, TBP, thyroxine binding globulin. Thyroid produces only 8 grams of T4 and 4 grams T3 daily. Serum T3 concentration is usually low because of reduced conversion from T4. The factors that destroyed of conversion T4-T3. Systemic disease. Starvation, anorexia. Surgical intervention. Newborn period. Gerontological period. Glucocorticosteroids. Beta-adrenoblocks. Amiodarone, cordaron. Propylthiouracil. Action of thyroid hormones. Genomic effects. The interaction of TH and its receptors is believed to precede other cellular events of messenger RNA and specific protein synthesis. Action of thyroid hormones. Maturation of the SNES. Lack of TH in the first year or two results in decreased brain cell size and number. Myelinization of axons is retarded, leading to abnormalities and dendritocarburization. Action of thyroid hormones. Maturation of the skeletal and dental system. Maintenance of oxidative metabolism and heart production. Control of temperature production. TH differentiates all tissues and organs. Diagnostic of thyroid gland disease. Visual and palpating method. Investigation of thyroid function, basal level of FRET3, FRET4. Functional tests, TSH. USG, radiography, scanning, etc. Biopsia. Diagnostic of thyroid gland disease. Serological tests. Markers of autoimmune disease, antibodies to thyroglobulin, thyroperoxidase, to TSH receptors. Markers of cancer, thyroglobulin, calcitonin. Goiter WHO, 1994, 0, goiter is absent. Goiter isn't visualized, but its size less than distal phalanx of thumb. 2. Goiter is palpated and visualized. Functional condition of thyroid influence may be as euthyroidism, hypothyroidism, hyperthyroidism, hypothyroidism, hypothyroidism, syndrome with particular or total deficiency T3 and T4 or theirs acts to target cells. Classification of hypothyroidism. Disturbances. Primary, defects of biosynthesis of T3, T4 due to pathology of thyroid gland. Secondary, decreasing T3, T4 due to deficiency of TSH, pituitary, or TRH, hypothalamus, or resistance of receptors for T3, T4. Classification of hypothyroidism. Onset. Congenital. Acquired, rare. Classification of hypothyroidism. Clinic and biologic data. Latent, subclinical, T3N, T4N. TSH greater than 10 μ/L. Manifestation of disease due to T4, at first, and T3. Complicate, etiology of congenital hypothyroidism. Primary hypothyroidism, thyroid dysgenesis, aplasia, hypoplasia, or ectopic gland. Inborn error of thyroid hormone synthesis, secretion, or utilization. Maternal goitrogen ingestion or radioactive iodine treatment. Iodine deficiency, endemic goiter. Autoimmune thyroiditis, etiology of congenital hypothyroidism, SEED. Hypothalamic or pituitary hypothyroidism. Pituitary aplasia. Septo-optic dysplasia. PIT1 mutation, deficiency TSH, GH, PROL. PROP1 mutation, deficiency TSH, GH, PROL, LH, FSH, ACT. Thyrotropin unresponsiveness, symptoms of congenital hypothyroidism. There is a tendency towards prolonged gestation with 1/3 of pregnancies lasting 42 weeks or more. Prolonged jaundice. Lethargy. Constipation. Feeding problems. Cold to touch. Signs of congenital hypothyroidism. Skin mottling and dry skin. Umbilical hernia and distended abdomen. Jaundice. Macroglossia. Large fontanelles. Wide sutures. Hoarse cry. Muscle hypotonia. Slow reflexes. Minority of CH puffy myxodematous face. Depressed nasal bridge with hypotelorism. Large protruding tongue with an open mouth. Cold, mottled skin. Short neck. Palpable fissures and narrow. Short fingers. Fat deposits between neck and shoulders. Hair is coarse, brittle and scanty. Hyaline reaches far down on the forehead. Diagnostic studies in hypothyroidism. Thyroid scan, 99 mTc or 123 IT3 resin uptake. Bone age. TSH. Free T4, with hypothalamic pituitary hypothyroidism suspected. TBG, if TBG deficiency suspected. Antithyroid antibodies, if history of maternal thyroiditis. Biochemical hallmarks of CH. Low serum T4 and T3 with evaluated TSH, primary. T3 normal, T4- severe or long-standing. T4 normal but TSH is elevated, compensative CH, transient or subclinical. T4 but TSH normal congenital TBG deficiency or hypothalamic pituitary hypothyroidism, biochemical hallmarks of CH. Other. Elevated serum cholesterol. Elevated creatine phosphokinase. Hyponatremia. Instrumental data. Slightly decrease heart rate and amplitude of R-wave, ECG. Increase projection period, left ventricular wall diameter, decrease LV chamber size and decrease cardiac output, ECG. Low amplitude diffuse slowing, EEG. Treatment L-thyroxine preterm 8 to 10 grams/kg 0 to 3 mo 10 to 15 grams/kg 1 to 3 years 4 to 6 grams/kg 3 to 10 years 3 to 4 grams/kg 10 to 15 years 2 to 4 grams/kg greater than 15 years 2 to 3 grams/kg. Etiology of acquired hypothyroidism. Chronic lymphocytic, Hashimoto's, thyroiditis, CLT. Subacute thyroiditis, de Quervain's. Goitrogens, iodide, thiouracil, etc. Thyroidectomy or ablation following radioactive iodine. Infiltrative disease, for example, cystinosis, histiocytosis x systemic disease. Etiology of acquired hypothyroidism, SEED. Hypothalamic or pituitary disease. Congenital thyroid disorders, for example, ectopia, may not decompensate until later childhood and thus may appear acquired. Peripheral resistance to thyroid hormones, including receptor defects. Iatrogenic, propylthiouracil, methimazole, iodides, lithium, amiodarone. Hemangiomas of the liver. Symptoms of acquired hypothyroidism. Slow growth. Puffiness. Decreased appetite. Constipation. Swollen thyroid gland. Lethargy. Drop in school performance. Cold intolerance. Galactorrhea. Menometrorrhagia, signs of acquired hypothyroidism. Short stature. Decreased growth velocity. Increased upper to lower segment ratio. Delayed dentition. Myxedema or mildly overweight. Goiter, signs of acquired hypothyroidism, SEED. Delayed reflex return. Dull, placid expression. Pale, thick, carotenemic, or cool skin. Muscle pseudohypertrophy. Delayed puberty or precocious puberty. Treatment same CH. Chronic thyroiditis Hashimoto disease. Clinical presentation. Goiter with euthyroidism. Toxic thyroiditis. Hypothyroidism with or without thyromegaly. Dysphagia, pain or pressure sensation in the neck, cough and headache have been reported. Diagnosis Hashimoto disease. T4 total and free, serum TSH. Biopsy. Antibodies test, antithyroglobulin. Antibodies to thyroperoxidase. Antimicrosomal test. Causes of thyrotoxicosis. Congenital, transient, neonatal Graves' disease. Acquired, Graves' disease. Functional adenoma. Thyroid cancer. TSH-secreting pituitary tumor. Iatrogenic. Graves' disease. Diffuse toxicity goiter, autoimmune pathology with prolonged elevation T3 and T4 and in ligament of thyroid gland, and in 70% cases with ophthalmopathy. Graves' disease, symptoms. Hyperactivity, irritability, altered mood. Fatigue, weakness. Goiter. Tachycardia and pulse pressure. Nervousness. Graves' disease, symptoms. Palpitations. Weight loss with appetite. Heat intolerance, increased sweating. Increased stool frequency. Thirst and polyuria. Oligomenorrhea, loss of libido. Graves' disease, SINGS. Sinus tachycardia, atrial fibrillation. Tremor, hyperkinesis. Warm, moist skin. Palmarerythema, onycholysis. Hair loss. Muscle weakness and wasting. Heart failure, psychosis, rare. Graves' disease ophthalmopathy. A feeling of grittiness and discomfort in the eye. Retrobulbar pressure or pain. Eyelid lag or retraction. Periorbital edema, charmosis, scleral eye injection. Graves' disease ophthalmopathy, SEED. Proptosis. Extraocular muscle dysfunction. Exposure keratitis. Optic neuropathy. Treatment of thyrotoxicosis. Thionomides, mercosolil 0.3 to half a milligram/kg divided to -3 times, 14 to 21 days, then supportive dose, 2.5 to 7.5 milligrams/daily 1 time. Beta-ab, anaprelin, 1 to 2 milligrams/kg divided 3 times. Euthyrosis, mercosolil 5 to 10 milligrams/daily with L-thyroxine 25 to 50 grams/daily. Surgical treatment, thyroid storm, crisis. Sudden onset. Fever. Profuse diaphoresis. Flushed warm skin. Tachycardia. Weakness, lethargy and confusion. Coma. nausea, vomiting, diarrhea. Enlarged liver, jaundice, thyroid storm, crisis. NARG 1 to 2 grams daily for immediately. Propylthiouracil 200 to 300 mg every 6 hours by nasogastric tube. Beta-AB, propranolol 0.1 mg/kg 4 or 4 mg/kg orally. Dexamethasone 1 to 2 mg every 6 hours. Supportive, correction of dehydration, antipyretics, digitalis to patients with cardiac failure.